So we are going to have two presentations today, one from the Department of Dermatology and another from the Department of Emergency Medicine in association with the CTVS, what happened to that patient, followed that. And we are going to have a short presentation about the project called Naira at the end of the presentation. We like all of you to stay for that. And over to Dr. Aparna.
Thank you, sir. Good morning to all. So today's topic is skin and systemic diseases. The systemic diseases and skin manifestations. It is a very vast topic, so I've included few clinical cases with systemic diseases and which is having cutaneous manifestations. So it is often provides crucial early clues. Even it's all signs of underlying systemic diseases, and it acts as a visible window into internal health issues. And so routine skin checks is vital for timely diagnosis and integrated care. So this is the first case. This patient, 75-year-old male, presented with this lesions. It was mild pruritic, not that much pruritic lesions. It was not erythematous. It was skin colored lesions, which was annular lesions. You can see that annular lesions. Keeping the differential diagnosis of granuloma annulare, interstitial granulomatous dermatitis, palisaded neutrophilic dermatosis, sarcoidosis, and annular elastrolytic giant cell granuloma. We did a skin biopsy. The skin biopsy results came as granuloma annulare. I'm not including the histopathology because it will be a very vast topic. So the histopathology came as granuloma annulare. The clinical lesion is also like annular lesions, and usually the systemic associations of granuloma annulare are diabetes mellitus. Most common associations are thyroid diseases and hyperlipidemia. The patient, while presenting, was not having any comorbidities, and other associations are autoimmune disorders like SLE, dermatomyositis, rheumatoid arthritis, and infections, especially like upper respiratory infections or any chronic infections like tuberculosis, and malignancies like hematological malignancies and solid tumors. And when evaluating, we did all the routine investigations, chest x-ray, USG, abdomen, everything was normal. The serum creatinine was 2.2, and usually the granuloma annulare is rare in kidney diseases, but this patient presented with that, and we referred the patient to nephrology, but unfortunately patient didn't go to nephrology, and 6 months later he had an elevated creatinine 6.5, and 6 months later only he presented with an elevated creatinine to the nephrology department. This is the second case. This is also granuloma annulare. While presenting, the patient had these lesions for past 4 or 5 years, and while presenting she didn't had any comorbidities, and while we are investigating, she had hyperlipidemia and hypothyroidism. This is also another case of granuloma annulare. The patient had joint pain, and she had an associated rheumatoid arthritis. So it is not caused by an infection, though it is an annular lesion. Most common differential diagnosis is tinea corporis, dermatophytosis, but it is not caused by any infection, and it is most common non-infectious granulomatous diseases, and it has multiple systemic associations. And so when you're seeing the granuloma annulare, we just need to evaluate and to rule out whether 50% of patients will be having systemic associations, and 50% of patients will not be having any systemic manifestations. So it usually the treatment if it depends on the extent of the disease. If it is very extensive, we have to go for phototherapy, retinoids, and HCQs. If it is not extensive, localized treatment like intralesional injections or local topical steroids, topical immunomodulators is enough for granuloma annulare. For some lesions, if it is limited, it is self-limited lesions also. So this is another case. The patient presented with hyperpigmented lesions. You can see in the neck and in the nose there are violaceous hyperpigmented patches. So it was asymptomatic. It was not pruritic. Only it was distributed in the photo exposed areas. It is photo distributed areas. And 25-year-old male. She had a family history of SLE. And initially, usually in lichen planus, this is lichen planus pigmentosus. There are different type of lichen planus. One of the type is lichen planus pigmentosus, which is presenting as violaceous patches, and it can be actinic and non-actinic. Actinic means it is due to sun exposure will increase the pigmentation, and it will be there in sun exposed areas. So this is especially in the sun exposed areas, that is actinic lichen planus pigmentosus. So usually the lichen planus pigmentosus, it will be asymptomatic, and treated for 1 month with topical steroid. Was very limited initially, and treated with topical immunomodulators and topical steroids, and it was not responding to the treatment, and her sister is having systemic lupus erythematosus. So we did ANA and ANA profile and came to us dsDNA positive. And so we have specific lesions of SLE and non-specific lesions of SLE, and lichen planus will come under this non-specific lesions of SLE. The specific lesions are photosensitivity, chronic cutaneous LE, DLE, malar rashes are the lupus profundus and panicleitis. These kind of lesions are specific lesions of SLE, and the lichen planus will come under non-specific lesion of SLE, like livedo reticularis, urticaria, bullous lesions, ulcers, panicleitis, alopecia, lichen planus are all non-specific lesions of SLE. So this is another case of lichen planus. You can see the violaceous plaque over the upper lip and erosive lesions in the lower lip. This is also lichen planus case. It is very erosive case, so we did a complete blood investigation and came to have HCV positive. This is another case of lichen planus, oral lichen planus, which is also very extensive oral lichen planus. So we did investigations, routine investigations and screening, and came to us HCV positivity. So the usual associations of lichen planus are hepatitis C infection, chronic liver disease, Hashimoto thyroiditis, hypothyroidism, connective tissue disorders like SLE, dermatomyositis, scleroderma, diabetes, dyslipidemia, anxiety, depression, and malignancies. This is a case of vasculitis, palpable purpura, bilateral overlook of 1 week duration. The 45-year-old male presented with these lesions, and while doing investigation, all routine was normal except HCV was positive. And so the cutaneous manifestation of HCV. So lichen planus is a cutaneous, it's the most common cutaneous manifestation of HCV infection is lichen planus. So along with that, cryoglobulin vasculitis is also presenting as a very common association with HCV. So other common associations are acquired porphyria cutaneous tarda, and other exacerbation of psoriasis, alopecia, polyarthritis nodosa, sarcoidosis, NME, that is necrolytic migratory erythema, and uncertain association like EM, erythema nodosum, Behçet's, and urticaria. So some nutritional dermatosis, like this is a case with hyperpigmentation of knuckles and perioral pigmentation, came to have vitamin B12 deficiency. This is a nutritional deficiency, vitamin A deficiency. This condition is called as phrinoderma. So it will be usually monomorphic lesions, hyperkeratotic monomorphic lesion, especially in the elbows, knees. So we have to, this is the most common association of this is vitamin A deficiency. And this is photodistributed dermatosis. The patient will be having photodermatosis, and exposed areas will be dermatitis, usually seen in vitamin B3 deficiency, niacin deficiency, and vitamin B6 deficiency. And angular stomatitis, which is very common, and most of the people will have this vitamin B deficiency for angular cheilitis and angular stomatitis. Then glossitis. If it is glossitis, we have to add zinc as well, because not like most common cause of stomatitis is B complex, but for glossitis there will definitely be zinc deficiency has to be considered, and iron deficiency as well. This is diaper area dermatitis. So recalcitrant diaper area dermatitis, definitely we should rule out zinc deficiency. This baby treated with zinc, and this very prolonged diaper area dermatitis was there, and zinc was supplemented. And along with that, early graying of hair, multiple deficiencies can be seen with early graying of hair like B12. Early gray means under 25 years of age, copper, iron, zinc, and selenium. And this is another case. This is a 45-year-old lady presented with the papules over the arms and upper limbs, so and hands. And on taking history, she had she's a cattle handler. Her occupation is milking cows. And so it is milker's nodules. It is a pseudo cowpox or farmyard pox. It is vaccinia virus, parapox virus infection. Usually it is self-limiting. It is similar type of lesions we can see in ORF. ORF is caused by it is from sheep and goat. This milker's nodule is from cattle. So this is another case of the patient presented with similar to granuloma annular. It is an annular lesion. The patient had fever. It is an acute presentation, but for granuloma annular, it will be a prolonged presentation with chronic presentation with asymptomatic lesions. Lesions which was very painful and burning sensation. Along with that, the patient had fever and the biopsy was done. This is another case. This is also a similar case. This patient presented with this kind of lesion. Patient is a chronic myeloid leukemia patient with the patient was on chemotherapy. And this is a case this patient didn't had any comorbidities, and while after only positive history was the patient had a upper respiratory infection 3 weeks back. So these two conditions, it's sweet syndrome, it's a fever more than 38 degrees Celsius, usually presented with acute presentation with fever. So it will be preceded by upper respiratory or gastrointestinal infection, and there will be typical inflammatory disorder or malignancy, pregnancy. These are the common association for sweet syndrome. And there will be WBC count elevated, and this conditions will respond mainly to steroids. Usual associations are malignancies, inflammatory bowel disease, autoimmune conditions like SLE, Sjogren's, Hashimoto's, Behçet's, dermatomyositis, post-infectious, lower respiratory and upper gastrointestinal diseases. So it has been so usually if it is a gastrointestinal infection or respiratory infection, it will be like 1 to 3 weeks. So we have to ask the patient any viral infection or any acute gastroenteritis has happened just 1 to 3 weeks prior. And other infections like HIV, viral hepatitis, tuberculosis, and other chlamydia infections are other associations of sweet syndrome. This is a very common condition usually associated with renal disease and diabetic diseases. This is diabetic mellitus. This is called Kyle's disease. So this male presented with this patient. This patient had a history of 20 years duration diabetes mellitus. This will be pruritic hyperkeratotic follicular papules which has a carbonization. Carbonization means this lesion will spread along with the trauma. So Kyle's disease, it is a perforating dermatosis, generalized hyperkeratotic papules with multiple discrete eruptive papules, usually associated with renal and disease and diabetes mellitus. And other associations are tuberculosis, scabies, in cutaneous diseases itself like atopic dermatitis, and neurodermatitis, malignancy, hepatic disorders, and congestive cardiac failure. So this is another type of reactive perforating. This Kyle's disease is a perforating dermatosis. There are 4 conditions in perforating dermatosis. One of it is Kyle's disease. Second is reactive perforating collagenoses. The difference, it is like Kyle's disease, it will be collagen extruding from that. Like that, a similar type of condition is reactive perforating collagenoses. This is also an association with the renal disease and diabetes mellitus. The patient had diabetes. This is perforating folliculitis. This is also a perforating dermatosis. So this is also associated with the diabetes. This patient had diabetes for past 20 years. So these are the perforating dermatosis, Kyle's disease, reactive perforating collagenoses, elastosis, perforans serpiginosum, and perforating folliculitis. So associations like renal failure, diabetes, hepatic. The most common is diabetes and renal disease. Other associations like hepatic dysfunction, HIV, hypothyroidism, hyperparathyroidism, atopic dermatitis, and malignancies. So this is a case, actually the patient was having this type of lesions for past 15 years. The patient was diagnosed at hidradenitis suppurativa. These lesions, these are the right side is the scarred lesions, the healed lesions in the buttocks and axilla. The active lesions were on this face, and we did a skin biopsy from surgery department. So I has taken a skin biopsy for this patient, and initially we did a biopsy, we did punch biopsy. The results was not conclusive, so we did with the help of surgery department, we did a skin deep wedge biopsy. The specimen was sent for tissue smear, even for skin biopsy, and staining for AFB. It was gene expert was negative, but we got an AFP positive. AFP staining was positive, so it is a non-tuberculous mycobacterial infection. And usual treatment is like ethambutol, azithromycin, isoniazid, and common combination therapy, because we didn't get any positive organism in the culture. So the combination empirical therapy we gave with the clarithromycin and moxifloxacin. This is a lesion after 6 weeks and after 12 weeks. So this patient presented to general medicine with breathlessness, and while the patient has a pruritus of past 1 year duration, he was taking azathioprine for past 1 year duration. He had the itch, pruritus, and a hyperpigmentation developed after 3 years, and on evaluating, the patient has hepatocellular carcinoma. So for 1 year, the patient had that pruritus, and the patient then developed serosclerodermatous changes and hyperpigmentation. So this is a case of some nodular lesions. I'll discuss few cases of nodular lesions of leg. This is a case of the patient presented with the 5 days duration of this lesion. It was very painful nodular lesions. Usual diagnosis is erythema nodosum. The common nodular presentation of leg, the common presentation, the most common diagnosis is erythema nodosum. There will be pain, tender nodules, which will heal with the hyperpigmentation or without hyperpigmentation. And the patient had a abdominal discomfort. So patient said he had blotting. So when we did a USG abdomen, there were CLD with mild splenomegaly and ill-defined hypoechoic lesions in the retroperitoneum abutting superior mesenteric vessels. This lesion, the CECT showed hypodense lesions in the head of pancreas. So it was actually not a erythema nodosum, it is pancreatic panniculitis. It is a very rare condition, usually seen in even in pancreatic malignancies. Only it will usually present in clear cell acinar malignancy. So it is an inflammation of subcutaneous tissue, and it is a very rare dermatological manifestation in pancreatic malignancy. And this is another case of, this is erythema nodosum. The patient has an associated rheumatoid arthritis. So the nodular lesions of leg, the most common thing is erythema nodosum. So it is acute nodular septal panniculitis, and it is usually sudden in onset with solid deep nodules, will be very painful, and it will be tender and usually localized to the legs. Sometimes it can be seen in arms also. The most common lot of bacterial infection can cause erythema nodosum. Viral infections, fungal infections, and non-infectious causes are drugs, malignancy, inflammatory bowel disease, Crohn's, ulcerative colitis, like other conditions like sarcoidosis, pregnancy, Whipple's disease, and Behçet's disease. This is a 30-year-old male patient who was retropositive and was on antiretroviral treatment, who had clotrimazole. So the patient developed erythema nodosum lesion. So the both are the triggers, like even the infection can cause, even the drug can cause this condition. This is a 22-year-old female presented with erythema nodosum, which had a LRTI like 1 week back. And this is a case of erythema nodosum. Had when doing Mando, it was like a very positive, very 30 Mando was positive for this case. So these are the few clinical scenarios, few systemic. This is a very vast topics. I'm not covering all this few cases I've discussed. So thank you.
Thank you, madam. Presentation on different manifestations, different causes for a single pattern. Any questions?
Yes, ma'am. Yes, definitely. If it is very severe, we have to give topic system for all the patients. We had to give the systemic steroids. But if we are suspecting, if this Mando was positive, so if we are suspecting any tuberculosis or any sarcoidosis, we should not start steroid immediately. So initially, we'll usually manage with NSAIDs or some hydroxychloroquine colchicine, which is not. If we are starting steroids, it will mask the condition. So after evaluation only. But if it is very severe, we have to give. It is very painful. We have to give the systemic steroids. And the main treatment is like, if the underlying etiology is getting treated only, this condition will completely get cured.
From the pediatric side, Enoxolin purpura is a very important condition. Most of the babies present with intussusception, for which we are not supposed to do surgery. Treat it conservatively. That would be a great lesson to us.
You have some triad, I think, for HSP, abdominal pain, skin manifestations, arthritis. So, yeah. So, madam, I have two questions. So, in the Milker's nodule, so how are you saying it is Milker's nodule? And so they get resolved after the removing from the job, or you do some biopsies? No, that is agreed. The thing is, if they have an associated other conditions, for example, vasculitis also can present like that, and cutaneous fungal infection can also have those kind of nodules. So we have had some cutaneous fungal infections after doing biopsies on these kind of nodules like histoplasm, like the histoplasmosis
if
and
it's a
all.
clear cut, if we have a history, if we are getting a proper history, it is not required. Extensive evaluation is not required for. But if it is, if we have
But we
a
have to be
doubt
sure that lesions are getting healed off when they removed from the jaw, or should we do biopsy? Because they can. How do we know that they are not having other causes of those similarly looking lesions?
that's what it will be self-limiting. So within 1 week, this lesion is for 1 or 2 weeks, it will be completely
So getting
healed. If it is not, we have to evaluate. Like the other conditions which present as implicated nodules are like histoplasmosis, cryptococcosis. All these lesions will be prolonged. It won't be like it is not a self-limiting condition. In that way, we have to go for tissue smear and skin biopsies.
I was just expecting some cutaneous fungal on the biopsies on them because it looked very classical on that. So another question in that NTM, and what was the genus code report on the final AAB culture?
So it was negative.
It was in the final AAB culture.
Yeah.
LPA, line probe assay.
We didn't do this, sir. It started with clarithromycin and moxifloxacin. We started. We didn't do.
That patient did not have any systemic manifestations.
No, sir. Everything was actually referred by from cardiology. Actually, patient acute presentation of it was planned for surgery actually. Then only noticed this lesions and sent to dermatology. It was treated as a hydradenitis suppurativa for past 15 years.
That is one of the close TD for cutaneous NTM.
Yeah, it was like giving steroids, doxycycline. It was going like that. So we, after seeing that lesions, it was not typical for a hydradenitis suppurativa because after healing, axillary lesion after healing, it didn't had any recurrence, and then started to other area. So in genital area, it is completely healed, and no other further episode was there in genital area. So it was so atypical for hydradenitis suppurativa, and the age of the patient was also very atypical for hydradenitis suppurativa. It started 15 years back. Usually if it is hydradenitis suppurativa, it will start in 10-15 years or like adolescent age. So like a very atypical presentation for that.
Thank you, madam. You have.
We are layman to these lesions. What is the role of artificial intelligence? We can take a photograph, focus it, and how much information can we take from artificial?
So we are seeing a lot of patients coming with this. Like they'll take the photograph of the lesion and just put it in Google, and they'll be coming with the different ma'am, is this tinea, is this eczema, is that. When taking the photograph, it is showing these lesions. But for cutaneous lesions, it has lot of differential diagnosis. So the sweet syndrome we saw, the granuloma annulare we saw, both are looking very similar. So the history is very, very important, like whether it has an acute presentation, chronic presentation, associated symptoms, any associated symptoms, systemic symptoms. So I don't think AI can help in all that.
No, if they follow AI, then they can end up with a condition wherein they will have all manifestations before they land up with it. It will be intelligent to refer to a dermatologist. Thank you, madam, for your nice presentations. Next presentation is going from the Department of Emergency Medicine, Dr. Melita. Over to you.
So, good morning, everyone. So, I'm here to present about aortic dissection and how do we approach in the emergency department. So, in the past 6 months, we had received about 4 to 5 cases of aortic dissection. So, I'm here to brief about aortic dissection and discuss about 2 different cases that we had received. So the challenge for the emergency physician is in making the diagnosis of acute aortic dissection, and in doing so as expediently as possible, as the mortality rate is 1 to 2% per hour. It is often a difficult diagnosis to make due to the multitude of different clinical presentation of the disease. So the aim of this presentation is to provide a firm knowledge base about aortic dissection and to increase its consideration in the differential diagnosis of any patient with appropriate signs and symptoms of the disease. So, as we all know, aortic dissection occurs following a tear in the intimal layer of the aorta with subsequent antegrade or retrograde flow of blood within the outer third layer of tunica media. So there are many classifications. So we follow the standard Stanford classification, which describes type A dissection involves the ascending aorta and or the arch vessels, while type B dissection involves only the descending aorta and occur distal to the origin of the left subclavian artery. So what are the predisposing factors? Notably, essential hypertension is by far the most commonest risk factor in approximately 70% of the cases. So the second most common is the connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, and other aortic valvular diseases. These conditions causes weakening of the tunica media layer of the aorta. So the incidence of the location of primary aortic tears, most common in the ascending aorta, about 70%, in the descending thoracic aorta, about 15 to 20%, and in the arc of aorta, about 10%, and in the abdominal aorta, it's less than 5%. So the clinical assessment, so as soon as we approach a patient suspecting aortic dissection, the history is the most essential part of the assessment as the of a patient, as it will be the patient's symptoms that will alert you to the possibility of aortic dissection. So the most common symptom is the pain, and in 85% of the patients the pain was abrupt in nature. The classical tearing interscapular pain was found to occur in only 50% of patients, regardless of whether they had type A or type B dissection. The pain in aortic dissection occurs in the anterior chest about 70 to 80% of the time in patients with type A dissection, and back pain occurs only in 50% of all the patients. Abdominal pain was found to be the third most common site. So syncope occurs about 10% of the time, which is more common in Stanford A classification. Physical examination, signs relating to aortic root dilatation like wide pulse pressure, diastolic murmur over the aortic area. Pulse deficit, a difference of 20 mmHg or more in the blood pressure between arms, a weaker central or peripheral pulse compared to the contralateral side. So hypertension is common about 49%, but hypotension occurs in 18% of cases, which makes the diagnosis more likely and worsens the prognosis. So the basic investigations that we do in the emergency, if we are suspecting aortic dissection, are basic 12-lead ECG, chest X-ray, and then bedside echocardiography, and then CT aortogram. So in ECG, it is very difficult to differentiate between aortic dissection from acute coronary syndrome on ECG, because both conditions are associated with ECG changes like STT changes, ST elevation, non-specific STT changes are also seen. The ECG is normal in only 19 to 31% of the patients. So in chest radiography, mediastinal widening or abnormal aortic contour is usually the most common finding in the chest X-ray. In bedside echocardiography, it makes the diagnosis of aortic dissection by identifying a free intimal flap within the aortic lumen, but its sensitivity is approximately 80% for type A dissection, but only for 50% for type B. So it does, however, accurately detect a pericardial effusion, aortic regurgitation, which provide valuable information for the surgeon to decide on the diagnosis. So the CT aortogram is the imaging modality of choice for diagnosis of dissection. CT can reliably identify a false lumen and true lumen and can provide additional details such as the anatomy of dissection, the location of the dissection flap, so how far it is extending into the vessels, and also the signs of end organ damage. So how do we manage those patients in the emergency department? So the initial management is opioid analgesics, because the patient will present with severe pain, and also it is vital that patients with suspected or proven dissection should have their blood pressure actively monitored and, if necessary, controlled. Hypertension is the major problem, since this increases the risk of propagation of the dissection. So beta blockers is the ideal first line treatment. It is short acting beta blockers like esmolol or labetalol are preferred over long acting beta blockers. So the definitive treatment depends upon the type of dissection. Type A dissection require open surgery to prevent rupture into the pericardial sac. Type B dissection or managed medically, but may require endovascular stenting if the patient has persistent pain or a rapidly expanding aortic diameter. So, this is the case we had received about 2 months back. Mr. Karthikeyan from Madurai, he was working here as a teacher in a private school. So, he is a 44-year-old male with a known case of hypertension, not started on any medication for the past 2 years. So, he presented to ER with a history of sudden onset back pain radiating to the abdomen, started around 1 a.m. in the midnight. So he presented with the classical interscapular pain. So on receiving, the BP was around 210/110. So we suspected aortic dissection. Saturation was around 90%. So we did a bedside echocardiography which showed moderate aortic regurgitation and dilated aortic root and ascending aorta, and the dissection was confirmed with the intimal flap seen on the suprasternal view. So then we did a CT aortogram which showed type A aortic dissection extending till common iliac arteries but without involving the arch vessels. So immediately the CTVS opinion was obtained. The emergency high risk modified Bental procedure was suggested by the CTVS team. The patient got operated in his hometown and he is doing well now. This was the findings of the first case. The ECG had STT changes. In echo, there was aortic valve dilatation, aortic root dilatation, and ascending aorta dilatation was also seen. CT aortogram showed the tear ascending from the starting from the ascending aorta till the common iliac arteries. The second case we received about 2 days back. So he's Mr. Ramesh Kumar, 69-year-old male with no non-comorbidities, atypical presentation with only history of giddiness for 1 day. On evaluation, BP was 90/60. Rest all vitals were normal. ECG showed inferior wall ischemic changes. So we did a bedside echocardiography which showed dissection flap in the ascending aorta involving arc vessels also, and hypokinesia of inferior wall was also seen. So we immediately sent the patient for CT aortogram which showed acute type A aortic dissection involving the arch vessels extending up to the bilateral iliac arteries. So patient attenders have been explained about the high mortality rate and the need of surgery. The very next day the patient was stabilized and modified Bental procedure with RCA venous grafting was done, and the patient is hemodynamically stable now. He is still admitted in the CTVS ICU. He is doing very well. He is extubated and he is conscious oriented now. So this was the ECG findings with the inferior wall changes. The chest radiograph showed typical mediastinal widening with abnormal aortic contour. This was the CT aortogram involving the arch vessels also with the true and false lumen. So what are the key learning points from the emergency point of view? Aortic tears most commonly occur in the ascending aorta with subsequent hemopericardium is the leading cause of death from acute aortic dissection. An abrupt or sudden onset thoracic pain occurs in 85% of patients with aortic dissection. The presence of an aortic diastolic murmur in the dyspneic patient must always alert the physician to the possibility of aortic dissection. Pulse deficit including significant difference in BP in both arms occurs only in 20% of cases. The 12-lead ECG is only completely normal in 30% of cases, with more than 40% of cases having STT changes. Hypertension is suspected or proven aortic dissection must be aggressively treated with suitable intravenous beta blocker, example esmolol or labetalol, because it is short acting. It also decreases the shear force on the aorta. Patients with type A dissection for whom surgery is considered appropriate must be transferred urgently. Patients with type B dissection with complications should be considered for endovascular intervention. Thank you. I request Dr. Purnachandar sir to briefly explain about the modified Bental procedure done for the second case.
Good morning everyone. Myself Dr. Purnachandar. I am one of the junior consultants in Department of CTVS. First of all, I would like to thank the supportive hospital administration and Loganathan sir for accepting our last minute request for this PPT. Incidentally, for both cases that she had presented, I was the junior consultant on duty. The first patient came with a typical excruciating, hellish kind of pain that is generally described. Due to cost constraints, patient had to be referred outside and they had gone back to the hometown. This case came to us 3 days before. This was a 69-year-old male with relatively asymptomatic, no any pain. Patient came just with giddiness. But credit to ER team, they did a screening echo and found there was a dissection there. And Dr. Vikram Vigneswar again confirmed it with a echo, and following which patient was sent for a CT. Patient had underlying AK or CKD. Outside creat was 2.2. But after explaining the risks and creatinine-induced nephropathy, patient was taken for a CT aortogram, which confirmed the diagnosis. And dissection flap was extending from the root till it was going to the bilateral iliacs, and right side it was extending into the common femoral as well. I'll just show you the brief CT. The axial section. You can see the dissection flap here. The arch. As per CT, it was extending into the arch vessels as well. This is the ascending aorta and this is the descending aorta. You can see the flap clearly. So this is the descending aorta. The left renal lumen was arising from the dissection flap, and the right coronary artery was not clearly opacified on the CT. So this is the division of common iliac. Here you can see the right, it's extending beyond the external iliac as well. This is the 3D reconstruction where you can see there is a dissection flap, the extension in it was suggestive of an extension into the arch vessels as well. So the attenders were counseled, we need to understand this disease is not just physically physically painful and emotionally exhausting. Cost wise also this has a brunt on the families. So after explaining this, and this patient's daughter is a periodontist in our hospital, so she understood all the severity involved in the disease and they agreed for surgical intervention. So patient was admitted overnight in our ICU and BP were optimized. Retrospectively found out that patient, despite telling no comorbidities, he had uncontrolled hypertension, but on presentation the pressures were normal, but we had to stabilize the pressures overnight, and to avoid further damage to the kidneys by bypass, we took him in the morning because he was stable hemodynamically. So we did a standard stenotomy and cannulation. We decided to go with the left femoral for arterial and the right atrial for the venous cannulation because the left femoral was not involved. Then on table we saw that RCA was RCA was eccentrically located and it was also torn off. And there was when we opened the pericardium, I'll just show you the video. When we opened the pericardium, there was huge significant hemopericardium, and there was significant clot over the RV as well, which suggested there was an rupture there, contained rupture. So this was a torn RCA, and so because there was a torn RCA, we had to do a on-table decision to do a single graft, venous graft to the RCA. And on opening the aorta, we found the arch vessels were completely intact. There was no dissection flap extending into the arch vessel. So we had to improvise on table. The initial plan was to go ahead with aortic valve either resuspension, aortic ascending aorta replacement with arch replacement, total arch replacement. But on table we found out there was only involvement of the root. So the false lumen can be cut off from the root itself. So we went ahead with a modified Bendal procedure, which is changing the aortic root along with a conduit of the aortic ascending aorta. So thereby preserving the arch and reducing the morbidities. Patient was cooled to 20 degrees with a circulatory arrest, and antegrade cerebral perfusion was maintained by both carotid arteries on table for a short brief. The arch was opened and inspected from within, which was contrasting to the CT. Despite a highly sensitive CT, we still found that intraoperatively the finding was varied from the imaging. So we just proceeded with a Bental. So following which the distal anastomosis and proximal anastomosis, de-airing was meticulously performed with carbon dioxide insufflation. Heart regained spontaneous electrical activity following the anastomosis, and patient was weaned off the cardiopulmonary bypass, and patient didn't require any inotropic support. After hemostasis, one of the most difficult and challenging perspective for a surgeon while operating for a Bental procedure. The hemostasis, after thorough hemostasis, patient was shifted to our CV ICU and was ventilated overnight. Patient was extubated on the following day. The renal parameters improved and there is no any neurological deficit for the patient. Thank you.
Thank you. Perfect solution to the presentation. Any questions?
For the first time we are hearing about 1 hour mortality. Can you please explain hourly mortality?
Sir, it's 1 to 2%.
What is that 1 hour mortality? Every 1 hour there is 1 or 2% mortality.
Patient deteriorates.
For how long?
For
By first 48 hours, the mortality goes up to 50%, sir. So every hourly 1% increases, and by 1 week, 90% of the patients eventually succumb to the dissection. Hardly 10% make beyond 1 week.
What are the end organs affected? You said in CT angiogram, it can tell what are the end organs affected.
So,
Only abdominal organs, brain.
We see on the dissection flap and see where the true lumen and false lumen, and what arteries arise from the true and the false lumens. Depending on that, also that this thing is made, surgical thing will be made, decision will be made.
So this is one of the mimic, sir, you can correct me if I'm wrong. So if you have an inferior LMI, but patient has severe abdominal pain, excruciating pain, tearing pain, going to the back, going to the abdomen, going to the limbs, I think we have to put all our money to rule out aortic dissection. So that was the internal medicine teaching. It still goes good. Anything to modify? Dr. Manindan, sir.
Patient with very low blood pressure has 90, 50, 90, 60 or less than 80, that means they are tamponade. So those patients won't give you time. So even before you start inducing, they might arrest at any patient. We had lost one patient who was just about to shift, that was some 3-4 years ago. They had to take some time to arrange money, make some decisions, get some consults. By the time they made a decision, when we tried to shift to the theatre, he almost arrested. When they arrest, it's very, very impossible, almost impossible to resuscitate them. So we have a high BP, you're a little safe. But you have a very low BP, that means you don't have time on your hands. You have to be really fast.
So anesthetic concern on aortic dissection. Okay, any questions? So for no more questions, we thank both of you and Dr. Aparna for their excellent presentation.